Right, so Elizabeth, you have a case?
Yes. So I just saw this 51-year-old female for chest discomfort, and I should start off before I say anything else that she's really anxious. She actually takes clonazepam on a daily basis. Her peripheral extremities were warm, well perfused. I didn't see any clubbing or cyanosis. Yeah.
So what do you think is going on?
Oh, well, she is so anxious, and I've seen her a couple times before here in the clinic, and I'm not so worried about this chest pain. I think she's just super, super anxious.
Okay, so what about her presentation makes you reassured that this isn't her heart?
Well, I guess partially the pain, because it's located right here in the chest, and
Coronary disease is rough, and it's a tough diagnosis because although we read in the textbooks that patients usually present with dull substernal chest pain radiating to their arm and their jaw with associated nausea and diaphoresis, a lot of patients don't present that way. You did some things very nicely. You gave a wonderful presentation. Your presentation, it was appropriately detailed. You talked about everything that I wanted to know in the history, and you described the pain well and all those associated symptoms. I couldn't think of another question that I wanted to ask. And your physical exam was also appropriately detailed in terms of the pertinent positives and the pertinent negatives, which really helped me sort out what I think might be going on. One thing that you can do is always be sure that one of the really nasty diagnoses isn't going on. So there are about 5 that you're really worried about: acute coronary syndrome, pericarditis or tamponade, pneumothorax, pulmonary embolism, and aortic dissection. And so when you see a patient with chest pain, you want to be pretty convinced walking out of the room that one of those things isn't going on, because the downside of missing one of those obviously is huge. And then kind of gauge your diagnostic workup that way.